Welcome to the fourth edition of Health Tech presented to you by the Bengal Chamber and Medical Super Specialty Hospital. This session is Trends in Health Tech. It would be chaired by Mr. Arnab Basu, who is the chairperson of IT Committee, the Bengal Chamber of Commerce and Industry, and managing partner, East and advisory leader of PwC. PwC is our knowledge partner. We have an overview of the thought paper being released in this forum in the earlier session by Mr. Sayantan Chatterjee, PwC Consulting Director. The thought paper is on transformation of patient journey in a virtual healthcare setup in the new normal. We are being joined by our speakers, Dr. Sujoy Kaur, Chief Medical Information Officer and Vice President at Apollo Hospitals. He will speak on ethics in digital health and clinical AI. Mr. Klaus F. Nielsen, Global Digital Health and Virtual Care Experts. He will speak on virtual care via telehealth. Mr. Obik Ghosh, Head Connected Digital Health, TCS Research on Wearable Technology, and Mr. Ayad Al-Musa, Middle East Healthcare IT Leader, PwC. With this, I would request Mr. Basu to please take the session forward.
Thank you, Angana. And again, a warm welcome to all the viewers in this session of Health Tech. So as Angana mentioned, the session is Trends in Health Tech, and we do have a fairly august gathering of speakers who are all specialists in their own fields who will talk about it. But I do want to, identify that we have chosen the speakers in a way that it gives you a 360 view of, how healthcare and, specifically patient care is getting transformed in the new normal. As I said, we would talk a bit about, Sayantan would talk a bit about the, thought paper that we've released. But I think it's a lot around, if you want to do anything in healthcare, really the foundation is around the data and around patient data, around health data, which in many cases is, of course, it's personalized and it's confidential. So we need to have the right framework of how health data can be amalgamated, how it can be prioritized, how it can be shared, how it can be even stored, because different countries have different legislations around even storing of some of these personal health data. And so we would have a bit of discussion around that, and then we have been talking and hearing and probably even use telehealth for ourselves. So how does the virtual care get transformed? We'll hear about that. A lot of virtual care is possible, probably using a fair amount of wearable technology. So we will have Ovik talk about that with us. And when we talk of wearable, it's not just about what I'm wearing while I'm exercising, but what I can be wearing on a regular basis and what it can do to transform healthcare and remote care in a country like ours. And then, of course, you can't be doing everything yourself. We obviously understand the demand supply constraints in this country in terms of, registered practitioners of, health. So to that extent, how much technology can, take over, whether it's in terms of intelligent automation, running the operations, remote monitoring, all of these are very, very critical pieces of the puzzle if this needs to work in a country the size of India and the complexity which it brings in. I think I would say the advantage that we have as a country is, of course, the mobile penetration of the country is currently at such a level that, and the technology has become so easy to use in some cases that it is now possible to do this. Not just with our, tier 2, tier 3 cities, but even in the hinterland. And again, what we are seeing is that in the new normal, even patients in the metro cities are choosing to go, remote, choosing to go virtual. So the trends which are emerging are quite interesting in a way, where people want to go probably faceless in an industry where traditionally people had not been, going faceless. And as we heard in the curtain raiser also, that these technologies have been there for some time, whether it's around, getting tested, around the diagnosis, telemedicine. All of these these are not new technologies, so to say, but it's probably also a change in the cultural mindset and the behavioral mindset where people are adopting it more. So I wouldn't talk too much in today's session. I would probably ask Sayantan if you can start off the session with your views of what our thought paper has sort of thrown up.
Thank you. I'll just be presenting the screen. So what we did as PwC is that we tried to work to backwards to say that what has literally this pandemic taught us, and what are some of the things that when I'm talking about virtual healthcare, as Arnav mentioned, some of the components have always been there. But what we tried to have a look is that what did this pandemic literally give that as a fillip? What are some of the things that it was not just a push, but what are some of the key aspects of what we called as a virtual care that got thrown up in a I would say forefront, where people started using it not just as an optional thing, but something which is very much part of how care is being delivered. And this is something which we believe is something which is going to be as the cliched new normal, but something which is going to be the new normal in terms of how care would be delivered, going not in the near future, but for some time too. And that's just for good. So I'll just take you through a few of the things that we look to cover in the paper. So what basically did the COVID-19 or the pandemic, what it did was, apart from all the disruption that it did on the economic front, on the socio-political thing, it also, I would say, interrupted the way we were living, for that matter. And because of that, and because of life that is related to health, so all the things that we had. So basically, be it increase some of the mental health because of social isolation, high degree of uncertainty, all the parents are working from home or anywhere, high attention to health. All this, what it did was that there was a whole, I would say, focus in terms of like how healthy or not non-healthy we were, and all the stress and all the, I would say, some of the lifestyle diseases which came through it. So that is literally what it did, and all the things, I think, as you will relate, literally propounded the way that we were looking at health internally and the way we were looking to basically go about it. That was literally the first thing that came to the forefront. And what it did, because of all the things that we were experiencing as individuals, as a community, as a family, is to see that how that we looked at the entire thing of healthcare was being delivered and how we were expecting. So if we were to think about it, healthcare was always associated with a doctor and a doctor in a healthcare facility, be it a primary, that COVID put on us, it basically made all of us realize that was it the form that we would like healthcare to be, or the care to be delivered to us. So in terms of it, like what it meant was that I was not too comfortable like moving out, or I'm not too comfortable in terms of going in a scenario which has I would say whole lot of chances of infection. And what I want as a patient is that can that care which was in the confines of the brick and mortar of those providers move to me. And I say move to me in a virtual mode, move to me which is in a sense which is the way that I need, when I need, and the form that I need. So all the things in terms of the personalized treatments, the things of being connected, what we were talking about, is something which all of a sudden became a reality. So during the lockdown, we were actually working with quite a few providers in the space, helping them as they were literally scrambling to be I would say be able to deliver care in this current fashion. So, and the first thing that is that how do I still be able to deliver that high care of care? How do I still get my care delivered, which is the doctors, to be able to treat my patient in the most effective way? How do I still instill that amount of trust within my patients to say that, hey, we are there for you, and especially in such a tough scenario that we are going in, and what was the means that we had. So in fact, I remember working with at least a couple of providers in the space where they had to say that, do we have the facility, do we have the infrastructure to be able to do all of this? So all the things, it's like it's one say to say that can we be doing it, but then how do we literally get about delivering that same amount of care? And it was not easy. It was something which it came about with I would say a lot of planning, but also in terms of other things which were literally pushed, and the pandemic was literally that push which helped us. I would say do that. And what was some of the things that which came up as a paradigm? It's like so rather than it just being on a device thing, something which is connected, continuous, and transparent. That's exactly what was the fundamentals of this virtual care, which was laid in front of us. And what most of the providers and the care delivery units said that how can I be basically enabling my care deliverers to deliver that care? So for a doctor who has always been delivering the care it's like seeing a patient in front, all of a sudden when the patients are not walking in, how do I still treat? And it's not just about the technology which enables, but there's a business process, there's a big amount of change management, which literally these institutions had to go through, and we were in as partners working with them in that journey. And that's something where literally the doctors had to be say that this is the new platform, this is the new tool, which is as intuitive as it can be, which helps you get that. And some of the things were there, but this is a forefront which this was basically the pandemic got them in the forefront to be used on I would say a very proactive scale and manner. And so when I say some of the things which came up in that, so one is the telemedicine concept of it. So one is that how can I be treating doctors being able to deliver care to the patients. The second care is the entire thing about the self-care thing. So when I look at a virtual care as a platform to say, so I need to be basically being able to not only get a visit or I would say consult with the doctor, but how do I basically care for myself, which is the entire concept of self-care. That is, it's not just about sickness that I need to be on this platform, but how do I have a mechanism to be able to be connected with my patients? And sorry, they may not be even patients, they might be your users of that platform in their wellness journey as well, which is the entire concept of being self-care. And literally the pandemic was a scenario where a lot of people were being, I would say, encouraged to be more, I would say, self-knowledgeable and aware of this thing. Second is in terms of your digital records, because this was one time where everything had to be on that platform. So some of the things in terms of your records and reports, scans, how do I have that on a single click, on a single access, so as to say, which is the thing of getting the records in place. Teleconsult is something which I mentioned, which has always been there, but now it came in, and so as to say that it is a seamless platform for a doctor to be interacting. In fact, while we were writing this paper and some of the interactions we had, one of the points which came from a medical practitioner was that, can it be as simple as like like the WhatsApp interface? And now WhatsApp is typically has laid that I would say benchmark of being simple, where I can literally click and I can see a patient, I can literally write notes, I can see the records while I'm writing the notes. Can it be that? And I don't have to worry what is the bandwidth that I have at my home. I don't have to worry about the security of the medical records. I don't have to be worrying that hopefully whom the patient that I'm meeting is the actual one. There is no duplicacy there. So all those things in a very simple, intuitive, and that is what literally when I look at a virtual care platform should be. For a medical practitioner, it should be something just simple, intuitive, easy, but at the same time provides all the features and functionalities as if the patient is sitting right in front of you. Then the thing about smart monitoring, because a lot of cases where now you had to be monitoring the patients who were the chronic care cases or the cases which were in the old age where they don't need to be literally coming to any health centers. How do I have the mechanism to be monitoring them? So can I get them onto this platform? So it is basically to say that I'm with you not only in your in your sickness, but also in your long-term care for that matter. And obviously the COVID-19 reporting, so as to say. So some of the things that basically looked at, some of the journeys that literally got transformed to say that I would now, instead of thinking about visiting any of the centers, and especially in this scenario where there was a lockdown, where in some cases people were prevented from going in, it was as seamless as taking your mobile or your laptop or your tab and clicking on it, getting registered using any of your social IDs or your registration that could be done, and in as simple as manner as getting, I would say, just like either a scan done or uploading your document and getting yourself registered, to consult being done, paying there, to the extent of even being able to order a test or a medicine and that getting delivered to your home, and then the tracking happening as the time goes on. So all that on one platform, and that's not something which is something where people are basically wishing for, but that's a reality where quite a few of the providers have taken that space and are working towards that, and that's where the journey is. So it's not I would say disconnected. I would say system, application, Windows. For them, it's just like one-stop shop. Can I be that one-stop? I would say in case it be like an Amazon or a Flipkart, that one-stop shop where I can literally log in to that, and anything that I need from healthcare comes from that provider. And they can be multiple providers for that matter as well. So again, depending on the setup, depending upon the country or the geography that we have, and depending also how the provider network is within the organization, both in the public and the private space. And that's actually what all this push about virtual care is being. So it's as seamless as sitting on your drawing room. Obviously, there will be some of the invasive or some of the procedures for which you would still need to be, but for quite a few of them, you don't need to literally be stepping out. And in fact, quite a few cases were to say that doctor is literally coming home. In fact, we had this the scenario in the old days where the doctor used to come home. Now this is a similar case where the doctor is literally coming home on your screen, on a virtual screen as well. And same goes for the doctor. Without, we would have to step out. Obviously, what it means that in terms of for all of, I would say, the key stakeholders, as to say, being the government, being the healthcare providers, the startups, the IT vendors. So there is a lot to be done in a collaborative manner, and it is being done. In fact, right from the government of India, what they did was in NDHM, which was a huge step, so as to say, where they laid out that how will this entire, I would say, digital platform be designed, what would be the means. So that was I would say, a very, very welcome step from the government to be going ahead with, and where they literally said that was the rolling. And the providers literally responded in a very positive manner. So all of them were literally, this was something they were all waiting for. We say that how will this, especially the platform would be working. So and there's a huge responsibility on the providers to now step up to be doing that. So be it, let's say, providers and taking the hospitals, clinics, and the doctors in the same space. And what it did, and what is now done, not only did, is basically it's a journey which has been there for some time. It just got accelerated. Is all the startups and the IT vendors. Literally, they're like, what it does is that provides them this entire, I would say, the gamut or the canvas to be coming up and working on this virtual care platform. Because it's to say that that can I have these solutions? Can I have these, I would say, modules and plugins on that platform to come in and literally start collaborating with one another? Because as a user, I'm looking at the experience. Literally, can healthcare be as simplified as doing an e-commerce transaction? That is literally the nirvana that we would be aiming for. And the startups and the IT vendors are literally working, I would say, very closely with the providers in taking that in that direction. And all thanks to the government of India for having given this in the time of the lockdown was clear vision from an engagement point of view. But obviously there would be some challenges, so as to say, because everything has its, in terms of, like, as we say, things in terms of obviously the financial transactions, because it's not that, it's still, obviously we have a high degree of mobile, I would say, penetration, so as to say. But in terms of for any of them, the patients to be using these virtually, it still needs a setup that they need. But the intent is, as we're saying, that how do we overcome this barrier? So how do we take this entire thing about it as simple or a platform or as easy to use or as inexpensive an application or tool that can be, so that that does not become an entry barrier for any of the patients, as we say. Similarly, from a provider point of view, the initial costs of setup and all, which used to be significantly high, has been now steadily decreasing. So, and also because you have, I would say, a fair play of the startups, so as to say, IT vendors in that way. So it's not just limited to a solution provider. It is not limited to a particular technology or solution, but as the way the platform goes, where everyone can come and contribute and work on that. That's exactly the model that's being worked out, especially from a virtual care thing. Technology, obviously, because there's no I would say, challenge which goes on with the technical. But the key thing is that technology, it's a challenge, but it's also the mechanism to overcome those challenges, I would say. So some of the things in terms of interoperability being worked out, network connectivity, all these would be there. The speed at which we are going, I'm sure that these challenges, I'm sure coming in the next 6 months, most of these challenges would have been converted into opportunities rather than just being challenges, so as to say. Behavioral, that's the first key thing. I remember I was talking about this to one of my uncles who's quite elderly and he has a chronic case, and I was saying that, are you sure that if I see a doctor on my iPad, he will be able to understand what am I how am I feeling? So that's behavior for me. So like, so can I trust that care being delivered through that platform? Can I trust that without having to move an inch from where you are, I would say the best care would be delivered. You would be able to order your medicine. The tests will all happen. So and not only that, it will be through a health companion, so as to say. So can that be there? So it's like literal to say that, can I have a health companion on that app? That's exactly what a behavioral change would be. Systemic, obviously, like all things, that there's not in terms of some of the mandates, some of the reimbursements, because there will be a lot of play between how the payers, the providers integrate. So all that will be there. But I would say, although these are the challenges, but these are all the opportunities as we go ahead to make this virtual care a reality. And that's exactly the message that we have. And typically, as PwC, we are working, as I mentioned, across the value chain, right from and with quite a few providers. I'm proud to be saying that, where we have helped traverse this journey with quite a few of the providers and making this a reality, not just about telling them what can be done, but not just the art of possibility, but making that possibility a reality for them. And that's I would say the message. So when I say virtual care in the cliched new normal, that's something which we are very proud that as a country, as a healthcare community, we are literally embarking on. So that's thank you, folks and gentlemen. That's all from my side.
Thank you, Shanta. Okay. Can we have Shujoy? Shujoy, would you speak next? Shujoy is speaking on ethics in digital health and clinical AI.
Thank you. First of all, a lot of thanks to Angana and team, to the BCCI team to actually invite me for this particular health tech conference, digital conference. Am I audible? Hello?
Yes, you are.
All right, thank you. So the topic that I was provided, and I thought it was quite relevant for the kind of the discussions that we're going to have today, was on ethics in digital health and clinical AI. And I'm going to talk about today on practical experience of, developing, validating about a couple of dozens of clinical AI solutions, working with the digital health platform 24/7, Apollo 24/7, that has been very recently launched. It's almost a year now. And what kind of frameworks that we have been able to develop within our systems to actually deploy them into the workflow of clinicians and to see how it augments their day-to-day practice. And I was hearing, Shantanu, an incredible work there on the paper that you had done, wherein there is a journey that the patient or the doctors or the clinicians are going to do, and they do completely on digital. But then there are certain questions, as I said, some challenges that you would face particularly on an ethical perspective, because we really don't know what is happening behind the black box. And that is where we want to go, see, understand, and it has to be explainable in many ways to actually work fine for all of us. So one of the things that we have been able to do at our institution across the network is to implement a policy, what we call as EASE. And EASE stands for ethical considerations, the principles that governs the ethical aspects of developing, validating, deploying AI and digital health. And then the important question of adoption. It always boils down to how much you are consuming the kind of technology that you're trying to build, whether, what are the change management that you're doing within your organizations to actually help them see the light of the day or the purpose of building them. And then comes the very important question of suitability. This acronym may not be staged in a way that it actually goes one by one or goes sequentially, but I think it covers what we necessarily want to look in a framework. And the suitability is the next one, which actually says what works and what doesn't work. And I was in a discussion yesterday by a very prestigious philanthropic organization who wanted to do some work on, child health and maternal health. And we boiled down to the question of suitability if the solutions that are going to come out are actually going to work for that group of people. And then the all-important things around the AI, and this is a debate that is going on world over, is about the explainability, how the clinical AI models or components of digital health are easier for understanding. And Shantanu gave an example by saying about an elderly gentleman who wants to know the value, the trust that the system encodes within itself to be workable for both the sides. And in that context, let's take up some of the things around the ethics part. And the first thing was about safety and non-maleficence. And, this is something which comes from the very core of the ethics in healthcare or in clinical medicine that we have to look at. But if you see on the right side, and this is something which came up in BMJ a couple of years back, it talks about how things are now moving from rule-based systems, clinical decision support systems, to supervised machine learning, to what we are now working on as a part of our certain high-grade AI tools like reinforcement learning, and how with those technology, bringing in simulations, reinforcement learning, and stuff like that are improving overall accuracy and integrity of models, which would help go and see that how they are going to be reflective of what exactly clinicians want in their individual workflow. But having said that, one of the important aspects that comes with safety and non-maleficence is about the whole idea that the model or the data with which you work with, is it inclusive? Is it something that can be used world over? And I bring a couple of things from the MIT Tech Journal and the 3 reports that came out on that. And the first one was about AI-driven dermatology could leave dark-skinned people behind. They would not diagnose people who are having certain lesions, including melanoma, in dark-skinned patients because of the fact that the model was never used those kind of data to actually for the training purpose. And if you don't see it in the training, you probably will not see it in the output or the outcome. And what they found out was that a lot of patients were being missed out in that. And the second was equally interesting. It was one of very good hospitals in Boston who developed an algorithm to actually follow up care in hospitals, particularly looking at readmissions. And that was particularly biased against people with color. And what it was doing was that they were not getting enough opportunities for readmission when that was warranted. And that was the algorithm was actually failing to define on that. And the third thing is that we have this ever increasing population, elderly population who are now moving to digital technology or who have already moved into digital technology. And they're looking into conversational AI in health, concerns on triage, when to report to the clinics or to the hospital emergency and stuff like that. And finally, I'm going to touch about a topic which is basically about decision-making and clinical handovers, which are also very, very important. The third thing is about the accountability process, where how do you design? What is your intended use? How do you look at the retrospective data, or what are your structural vulnerabilities on the entire workflow of developing and validating a clinical AI model, or even for the digital health model? And this is one of the papers that came up again in MIT SMR, which looked at particularly on scoping, mapping, collection of the artifacts, testing and reflection, and looking at the whole process in a way that would make it more auditable and accountable going forward. The next one is on the efficacy, and we have looked at efficacy in a very different way in traditional studies, but in AI, we would have to look at what works for you in the retrospective data may not work for you in the prospective way. And there are good tools to use, actually. There are tools like there are tools and metrics that are available in terms of precision recall or predictive values or likelihood ratios, which are coming more and more prominent as we see more papers happening around clinical AI and all of that. But I wanted to talk about this accuracy, and we know about Google Health, and in fact, I have been also in one or the other way part of this work. And the algorithm that they developed for detecting diabetes retinopathy was excellent when it was getting trained and when it was going through the initial validation with the retrospective cohort. But when they implemented it on the ground, they found out the efficacies were down by almost half. And the accuracies were falling down in that way. And the reason being, it was the time that were being taken for rejection or retake of an image, particularly in senior citizens or other population. And then, of course, the whole purpose about connectivity, internet connectivity, and stuff like that. The other thing is that what actually didn't work out for them was that they didn't focus much on the workflows. They were doing an excellent job towards the building the model and validating it, but they were not actually focusing on the workflows. And that's where when I go back to my teaching classes at IIM Calcutta, I always tell people that the digital is not just enough. You would need to actually have, sorry for this, you would actually have to have stuffs like design thinking brought over on the top of clinical AI to actually make it more relevant. The Achilles heel of AI is about the integrity, is about what you put into your data that comes out as an output. We all know about the GIGO effect, the garbage in, garbage out, and all stuff like that. I want to focus on fairness and inclusivity, and that is one of the main problems that we face today with digital health or ethics and stuff like that. And that is one of the things, and I heard Dr. Rupali Basu speak about using Aadhaar card and COVID vaccination drive. And I want to bring into a study that was published from India onto WHO bulletin about a couple of years back. And this study actually talked about when the Aadhaar card was linked with people with HIV, people living with HIV and tuberculosis, associated tuberculosis, the dropout rates for people, because their Aadhaar cards were actually exposed, was staggering. People did not went up and picked up their the heart medication and others highly active antiretroviral therapy medications, because they were exposed to, the data sets were exposed and people could actually identify people with living with HIV with their, with their Aadhaar card. And that got published in WHO, and you can understand the connotations of this, which is not just about a clinical, but also socio-economical, and also about, the whole ethical principles associated with it. The other thing that is very exciting about looking at ethics is the whole context of bias. And we've studied the bias in a very, very distinct way. And we've seen the bias comes from model development, in which you pick and choose or cherry pick your population and then show some results and see how do you go about that. But bias also comes in when you are actually deploying that thing, in which are the group of people that you are actually going to use your digital health, or you are not going to make it to a section of population and not to the other section of population. So that those kind of things are needed to be addressed where you are developing solutions for clinical AI, or even for that matter, in that way. And we can go on and on discussing around bias and all of that, but I thought it is important to actually look at the bias also from the deployment perspective. So to summarize in terms of the adoption perspective, what are the other things that are required? And I think the previous speakers talked about interoperability and universalization. They talked about calibration and benchmarking, understanding the clinical relevant outcomes, and of course, looking at patient safety as such. When you have all of these components, your adoptions are going to be used. I'll come back to the other very important aspect of this is actually the suitability consideration, where the first question that you need to ask is what clinical or public health problem that you're going to solve. Next, address the bias. Third, look at what exactly the knowledge interpretation or the causal structure or, the kind of information that you are going to generate. And lastly, you would have to think that anything that you work with has to be in a way that clinicians and AI come together. You have to augment their workflow. And in that way, you have to understand when the algorithm hands it over to the clinician and the clinician hands it over to the algorithm. That is something that is still under research, but that is something which would actually help in rolling out more and more of digital programs and clinical AI going forward. Explainability is the last portion of this. If you look at the steps around the explainability, you have to find out, you verify before deciding. And this is particularly important for the clinicians. They would need to understand, build the trust in the system, and convey that trust to the patients to actually make it that way. And the third thing is it would become more and more relevant when we actually move from prediction to, and Dr. Ravi Chakraborty was talking about predictive medicine. I think what is important in going future is to actually bring causal inference to the prediction, where we are able to understand that this decision of mine by providing the patient the chemotherapy and radiotherapy is going to have an effect over the 5-year survivability on that. And what if I didn't choose those two and I choose the surgery over it? What are those kind of models going to give us? What are those kind of understanding going to give us? Those kind of things will make the system much more robust. And of course, the new clinical insights are the other part of the story, which also always goes to come in, particularly in drug development and other areas as well. So this is the work that we very recently did with World Economic Forum, got published in December 2020, where we actually deliberated a team of about 8-10 people worldwide. We worked on to develop a framework, which is probably going to become the standards of preparing clinical AI or chatbots across the world. And this is being done through one of my friends, Mr. Venkat from Mitsubishi, who actually worked with the World Economic Forum to develop this. So my last slide, so to put it in this way, if we could just ask the right questions at the time to actually see more inclusiveness and fairness in the whole process of building digital health or clinical AI. First, what is the process of decision-making and oversight? What are the benefits to the society, to the people, to the clinicians at large? And have we worked around a dynamic and informed consent, evaluating or communicating about the risk? And what are the stakeholders able to participate into that? How interactive that is. This is something which comes from IEEE. I find this as one of the ways by which we put in how we bring in more and more ethical standards into clinical AI and digital health. Thank you for the opportunity.
Thank you, Sridhar. So, Klaus, can you have you go next?
Yes, please. I will start share here. So, can you see my screen? Yes. Okay. So, thank you so much. So, I am Klaus Nielsen, and thank you for the opportunity to be able to join you virtually, unfortunately, in India, in Bengal. So I'm the co-founder of the Data for Good Foundation. I will explain about it, but it's a Danish data intermediary I've been working with for 5 years. I'm in the board and have been co-founding it. It's about trying to be enabled to represent the citizen in the data economy. I'm currently sitting in Bangkok, so it's getting dark here. I'm looking out at the skyline. So I've been here for the last year, I haven't moved much, and I'm the former vice chair of Personal Connected Health Alliance, which is one of the organizations trying to make interoperability within the personal connected health space. If anyone wants to, let's see if I can move to the next one here. Yeah, now I can. Yeah, so if you want to tweet or you want to do something, this is my handle. So just to make it very brief, I'm Danish. If you Google it, you will find this. So technically in the US or UK, I will be sold as a Danish. I'm basically born here, but I'm now on the other side of the planet. Let me make it brief. Just tell you a little bit about Denmark. So Denmark has a tax-paid healthcare system, which costs the half of what it cost in the US. This is even old numbers. It's probably worse now. It is very high quality. It is for all, even poor people, and we have a very good satisfaction rate. I don't think you can say the same for US, even though they claim we are socialist, but that's okay. I'm happy. So just to let you know, in Denmark, this is my background. When I work into this space and understand it, I can buy and sell a house 100% digital. And I've even tried this. I got a digital divorce in 5 minutes, so I can highly recommend it for people that want to get rid of stamps and paper. And I know I talked to you in India. You can't even believe this. This is my world, okay? What you are doing in India is trying to develop unique personal data. You're doing a hell of a lot of work on trying to get data in on people and have a unique person identifier. We have had that since the 70s, meaning that we have unique personal health records. This is showing my personal health records going many, many years back. Just to let you know, we are talking about virtual care. This is something where in my country we have had it implemented nationally since 2013. We have even very, very good cost savings on a public healthcare system, how much you can save. Even though we have it, it's still a challenge on the adoption side. I implemented my first aging at home remote patient monitoring projects back in 2007, and some of them are still alive using the same equipment. One of the challenges has been, even though we are one of the most digitalized countries in the world, is to get doctors on board. And this is one of the learning points that I still wonder about is we spend maybe 8 to 10 years to get our private GP system, which is technically a private system that is reimbursed by the government. But when they couldn't see any people, they will not get paid for any consultations. They get paid by that. So that's we didn't manage for 5 to 10 years to actually get them to adopt video consultation. But with the pandemic, also as we heard, this suddenly changes everything. So it's not a technology issue. This technology has been available for over 10 years in the Danish public health system. It took 4 weeks to get almost 100% rollout. This is only a political decision. So if you want to be virtual and there is benefits for it and it starts to hurt financially, people can get things done. Let's change topic. So this is my old home in Denmark, which I don't have anymore. I'm now based in Bangkok. I have no intentions of going to a COVID place. I'm happily safe here. But this is my old wooden summer house. I have, of course, equipped with sensors. I had all these gadgets. I still have them. I have exchanged some of them. The weight scale is here in my bathroom. I still have the blood pressure monitor. I've had them for 11 years. As everybody knows, we do a lot of sensors. And now you can see my video. So one of the few gadgets I do absolutely not want to have is to measure my hair health and hair quality. So I don't buy this one. Just to let you know, I am a quantified self guy. But let me go back to something that is much more interesting, because what I see here is a real pandemic in terms of using virtual care for something good, is to battle this pandemic. And this is, I have not taken India into this equation. Just took some old numbers from Southeast Asia, where I'm placed right now. And this is even worse. This is worse numbers we have now. This is leading to a lot of the diseases we have. And at the same time, in this part of the world, we have a lack of access to clinicians. So this is where the virtual health, the remote patient monitoring tools, whatever you call it, anything with devices, can start to do a big difference. But before we go into that, let me explain you why I a little bit know about this. And let me explain, just sorry, I have to put a disclaimer. This is me. It is in 2007. And the formula you see down here is the formula for body fat. You can see it here, right? Here you see, that is the formula for body fat, if you don't know how it looks like. And I had way too much of it. And I got one number in my GP system that nobody reacted to me. This number means you're pre-diabetic. I didn't know what that meant. A simple machine. This is not a lot of data. We just talk 2 digits that could have warned the doctor on the screen. This guy is he has on a blood glucose lab result a number 48. Nothing happened. Of course, I was later diagnosed at diabetes 2, so I don't want to be a diabetes 2 patient. So I started my work of trying to exercise, and you can see how much it worked. Not only exercise, did everything that is needed to reverse my diabetes, and I came back to the green area. If you look into the data I collected, how much exercise means when having a good control of your glucose and not having a glucose control. Here you have my data. These are my data. I don't share it with anyone. I share it with Roche, and they probably use it for some AI. They don't know what I eat, but this is my food. I love to make food. So I changed my body completely to look very ugly from 2007 to 2017. Unfortunately, my journey is I still kept being diabetic. I got probably because of the way I was eating, I don't know. But I got a cancer diagnosis in 2017 that set me back on my. So the whole problem with my diabetes had probably been related to my cancer. I survived. It was found early. This is also a good thing about, if you know that I have cancer, that I have diabetes, what I'm eating, some of my symptoms can actually detect some cancer types early if you have data from me as a person. But we don't have access to that as of today. I was luckily found in a hospital here in Thailand. I'm happily cured. But what I'm actually looking at is, just take a use case for for some of the things we are trying to help people with. So the use case of virtual care and remote patient monitoring is diabetes. We have an explosion of diabetes 2 and now also diabetes 1. This is one of the issues. Only 6% is in good control. And diabetes is a complicated thing. It's like you have to navigate when you cannot produce your own insulin for either for different reasons, either because you are attacked by the body at diabetes 1, or you I don't know how many of you guys know this disease, and then diabetes 2, which is lifestyle, where your diabetes get less efficient. So there is like millions of people living with this caused by the obesity pandemic. This is killing far more people than the COVID right now. And we are not having a lot of tools to combat this. So it is like having if you think of it as a flight captain that has to navigate his glucose level, where it's where you have insulin. Insulin is controlled by what type of insulin you have, basal insulin and then the rapid acting insulin. Then you have to know how much carbs there is in food. Then you need to know if you have been active, not active. Are you planning to be active? Do you have any diseases? This is a very, very difficult task to be in control of your diabetes. My son has diabetes 1. He knows that. He dreams of having tools like an airline captain, not to crash if he's too low and injects too much insulin, or get up in the sky because he's sky high because he eats something that was carbs and he didn't know. So let's take a simple case of how complex it is when we talk about making the data input just for handling diabetes, which is a pretty normal NCD disease. And this is actually tools I'm using today. I'm using these tools here. The glucose pen cannot right now. This one up here cannot yet transmit data, but I know they're working on it. So technically, the only missing parameter I have is the food, where I'm trying to use some AI tools. Trying to get this into this kind of system we have in my country. I'm showing Endomondo now killed and we things. But we have a lot of data in the cloud and difficulty sharing it. I've been working with this topic. So one of the challenges of bringing virtual care to the masses is to get the interoperability. It was mentioned before, and it's still the same problem. And then if you can get that, you can get my data. So my data, here's my weight data since 2011. And for me, battling with, now I'm a type 1 diabetic, because you can see on this, I got this number and I couldn't understand it. If I go back, I go back to this one. So what happened here is I suddenly lost a lot of weight. I got my cancer here in 2017. You can see here that I was going down in weight. I was in pretty good shape. I've been exercising, as you can see on my stats, and I have been moving my body fat around. And now I suddenly became a type 1 diabetic. So this is data. And now I have this one. But you know, I have more questions than answers. And if you look at the healthcare system, it is not patient-centric, no matter what. Sorry, doctors, but what you say to me, now I take the role as a patient. No, it is not patient-centric. We have the oncology, which is and has to be highly specialized. And I don't expect them to understand much about my diabetes. And that is just how it is. That's in the endocrinology field. And this is patient-centric system that when you talk to a hospital, they say, yeah, we have the patient in the center. No, you do not. Actually, I'm left alone. That is how it works. I have accepted this fact. And I know it's not easy because I've tried to innovate public health system for long. And it is still, when we look into the model of healthcare, it is still a one-size-fits-all where you all find, I think in the Rania Hospital, I saw that at Dr. Shetty's office, he said, healthcare is only about price and protocol. And I guess he's right. So what we are trying to do with the virtual care, what has the potential, is to try to make this shift from sick care to health care. Because what we are looking at now is we are only doing where there is an accident. Why didn't I get notified when I was 48 in diabetes that I could actually reverse my diabetes? Maybe they've even found my cancer and other stuff because you can see that. But there is no there is no feedback loop from these data coming into my digital records yet. There has been no AI put on it to make alerts and warning systems or whatever. But what we can do is we can try to work on trying to focus more on this part of the system, because this is where we end up, and we generate a lot of cost. So if we can try to stop that, that would be a main goal. So what happened to me is I got diabetes 1. So I'm trying to get help. I'm measuring my data. This is just one app that is one of the most popular one called OneDrop, where it takes data from a lot of sources. I'm not able to share. I can share this to my coach. And this is the interesting part. I have now a coach that looks after me, motivates me, because one of the problems when you have a chronic disease is, and you can reverse it, is how can you get out of it? This is into the self-care we are talking about before. So now I measure myself. I can share these data. I cannot share it to my doctor in Denmark. I have to send it very, very old school on paper in PDF to a very, very secure email address. And she doesn't get the data in between my visits. Okay. So now I have subscribed to a private service. So this is one of the issues of the data sharing. We know that it's happening and people are taking my data and it's being used. We know that Google is using it. We don't even need to apply anymore. They know everything about what we are doing, what we are talking about right now. I think everyone in this room knows. If you haven't seen the documentary on Netflix, go and watch it about the Cambridge Analytica scandal. But what we see now is quite interesting, because I have a lot of data. I want to share it. I need it. I would love to share it, but in this world, there are some people I don't trust. Right now, we have, let's say, a possible digital divorce coming up between these two guys. It's quite evident. It's also quite evident that we have lost control of our digital lives. I have so many apps. They are spying on me. They are taking my data. You can see what happened with WhatsApp when Facebook set new privacy rules and people flocked to Signal and Telegram. Honestly, as a private citizen, I think we have lost control of the data we are creating in all our apps. This is a big issue, and I'm happy you mentioned also the trust issue previously, also the previous speakers, because creating trust is something you have to earn, okay? So when I create trust in a relationship, I have to earn the trust in my relationship that I'm a good guy. If I have to have trust in a currency, it's something I earn. We tend to forget that. Now, if you have trust in the dollar, it's backed by the US government. So I'm just telling that creating trust is a problem. Let me go into another topic, which is interesting, because all of these data is about how can we trust data, and then right now our data is being abused by a lot of data, both governments, but also I think there's about 150 data mining companies. And I know this is a big industry, and I don't think we can stop it. It's also okay. But the European Commission have tried to do something about it, and you probably heard about GDPR. Here in Thailand, we now have PDPA. I think it's a good thing if we can try to control our data, that we can make it easy, securely, and simple. So some of the things I think is interesting on terms of talking about how we can get AI to be enabled is how can we easily share our data, do our consents. So I'm working privately on a blockchain that is a private serving blockchain that technically works on the new decentralized web. It could be like a health kit. You see here the kind of just think about the health kit model from the Apple iPhone, where you then can see who you get access to. And we try to test that on several remote patient monitoring and Vital Beats app from Denmark. It's a Danish project where we then can control this. And then we combine this with something quite interesting, where you can do this secure multi-party computation, where we have computing nodes, so we can actually anonymize my data. And why we need that is take the example of tracking of COVID, where Singapore police went in and used the data for criminal purposes. Now it was illegal, and now they have legalized it. But do you think people want to now use the app anymore? Trust is something you gain, and we try to make a infrastructure now where we can actually do this. So just quickly to do commercial of what I've been spending 5 years without getting paid and investing my own money with a lot of people in Denmark is to do a data foundation structure where you can have citizen control, transparency, overview, and cooperation. And we are testing it out with a lot of pharmaceuticals. And this is how I think that my data, combining the story, can come back from what we looked at before, my private data, together with public available data, my Danish personal identified data, and maybe my genome data, which I then give access to APIs, so I don't technically move the data, to a consent hub that is then run by a privacy-preserving blockchain. And then we apply this cryptography, multi-party computation, where we then can give access to analysts to give back insights. This is a data ethical way of taking my weight data, my private data, my glucose measurements into the system, get it back into me as insights, and that is how we should do it. And I could even get paid for this, and that's why we call it a health data exchange. And now we have a fair data economy, a fair solution where my virtual care apps, all my data I collect combined with this can work. This is a little side topic, I know that. This is our portfolio, this is the partners that we are working with. But I want to finish this, and I know I went a little bit off topic of the virtual care, but I think what we are aiming for is that I can get a self-care model where my data can be used to advise me on making changes in my current lifestyle, how I sleep, because I know it affects my data, it affects my life. If I don't sleep properly, if I'm not exercising, if I'm not healthy. And I think the healthcare system needs to accept that they can't solve everything. So we need people in between. A new growing business is the wellness coaching business. This is the one I'm working with here in Thailand in Be Healthy Asia, where we try to help Phuket that has empty hotels, fitness coaches, trainers, chefs that can learn about food, do the education part about patient, and try to help people get motivated to not end into the expensive healthcare system. That is my 10 cents. Thank you for listening to me. And if you want to get hold of me, here's my credentials. And I will now stop sharing and love to engage in a discussion. Where is the stop share? I have to go here. Yep. Where's Zoom? Okay. Stop share.
Thank you, Klaus. That was really interesting. So can we have a pick after this?
Sure.
There's a break now.
Okay.
No, I don't think we are taking a break.
Oh.
Or did Angana suggest a break? Angana, are you there?
So we are going ahead with the session.
Yeah. Okay. Thank you. So, Avik, over to you.
Sure. Good afternoon, evening, and morning, everybody, based on where you are. And I'm going to talk about a little more technical topic, that is how to use and how well wearables have been used in healthcare. So do let me know when you can see my screen. I'll try to share it. Hope you can see my screen now.
Yes, your screen can be seen. Yeah.
Sure. So here we are going to talk about how wearables can basically help in remote care or remote healthcare. So here, basically my talk, I will cover more on the current state-of-the-art wearables, not like very specialized wearables that may be designed specifically for certain use, but what we usually have with us right now, and which is the smartwatch, right? So what all can we do with a smartwatch that exists with us today? So one thing definitely I think the Fitbits and the Apple Watches of the world have been doing for long has been activity monitoring, right? Now, well, they do activity monitoring. They basically concentrate more on step-based activities. Recently, Apple has come up with some fall detection algorithm on their wearable. However, the band or the watch can be used for detecting more complex activities as well, including activities like eating or smoking, which also give good insight into what the patient has been doing or what the subject has been doing throughout the day. The second parameter of interest, which has become very much of importance now, is the proximity. So when I say proximity is the same as what we detect for this COVID, the social distancing. So we can, detect and monitor interaction levels also using the smartwatch, because most of them have a Bluetooth built in, using which we can do some proximity sensing. Some physiological sensing, of course, most of them have a pulse sensor, and they also have some of them have ECG as well, but we will concentrate here on the pulse sensing. And finally, you'll see how the GSR, or the galvanic skin resistance, present in few of the watches can be used for some cognitive sensing as well. So moving into activity monitoring. So while as I said, like there are the step-based activities are being monitored by most of the wearables, that only provides a very scanty view of the actual activity that the person does throughout the day. So there are many activities that the physician may be interested in, especially for a patient who needs some assistance. So meaning the activities of daily living, like eating, exercising, brushing teeth, whether they are doing it properly or not. Now the problem with this approach and using the existing wearable is, while it is good enough, the wearable batteries or the wearable power is good enough for detecting activities during the 2 hours of exercise that we do. If we try to monitor all these different activities throughout the day, then it's a serious battery issue for the current wearables. So we tried to solve this problem, and we designed a hierarchical classification model, whereby we could actually use the AI to both optimize the battery as well as detect which sensors need to be turned on at which point. For example, the accelerometer sensor on the wearable or the watch is the least energy hungry sensor that is there. So we can opportunistically turn on the accelerometer at a lower sampling rate to detect if there is an upper body gesture happening. And once we can detect that the arm is moving in the way of some activity is happening, we can turn on the gyro, which is a more energy hungry sensor, to detect whether the person is actually eating or smoking or brushing his teeth, right? So these kind of trade-offs can be done, and throughout that we could show that we can actually map the day in a life of a subject. And this was done on an elderly care facility. So basically we are monitoring geriatric patients for their daily activities, because they are basically living alone in ambient assisted living scenarios, and this was the work we had done. So I'll move to the next one. So this is basically the same thing that Arogya Setu also does. So this is proximity monitoring. However, what we realized is that apart from monitoring proximity to give risk score, it may be also interesting and maybe also important in enterprise scenario when we open after COVID, to also give some real-time alerts on to people if they are coming too close, right? So can we use the watch or the phone to give real-time alerts? So that is like, it is more intervention for prevention rather than just detecting that okay, you have been coming in close contact with somebody. So even if the we don't know whether the other person is infected or not, we can enforce in some way that yes, you should be that 6 feet or 2 meters away from each other. right, at all times. While this does not hold good for home scenario, but we can use some location trigger to turn it on only when the person is in the office or enterprise scenario, or the factory scenario, where by we can ensure that they don't come in close proximity with each other, and if they accidentally do, they are given an early warning. Right, and just like the all the apps in this, we also keep the data anonymized and expose the identity only to a trusted server, whereby only the fact that you have been in close proximity to somebody who got infected is only the part shared. So the identity of the users are never shared across devices. So the third one is again using what we call the pulse sensor that is there in all wearables. So while we know that this has been used widely to detect heart rates, what we tried to detect was the cardiac fatigue. So what do you mean by cardiac fatigue? Is that when you do an activity, which is also can be detected easily using a smartwatch. So if we can detect that you have done the activity with a certain MET value for a certain duration, so we can see whether you are having the rise in heart rate that you are having, or the rise in breathing rate, the dyspnea you are having, is correlating or corroborating with the kind of activity you have done. So let's say a 40-year-old person with certain BMI has done certain activity, then is it normal or abnormal for the person to have certain level of heart rate increase and certain duration before the heart rate again comes back to the basal heart rate? So using these, we could actually determine if the person was having some kind of cardiac problem or cardiopulmonary problem, whereby we can detect that there is a abnormal raise in heart rate or dyspnea or other problem that the person is facing after a normal daily activity, right, like climbing a flight of stairs. So this was another work we had done. And the third and final work that I'm going to discuss is about this mental workload analysis. So here again, what we had tried to do was that, given a task, can we use the wearable sensors to understand what is the level of mental workload or stress felt by the person during that task. So since it is not very ethical to actually provide some stressful work to a person, so what we did was we could determine we designed a game which had two levels, like boredom and flow. So the game was very slow, then the person would get bored, and then there is a flow state where a healthy stress is being applied. So we saw that we could actually use this GSR signal to separate out the boredom and the flow states, and we could devise a score which could tell what is the level of mental workload that the person is facing. So this can be used for many cases, like when an elderly person is doing a task, or when a student is taking a lesson, or any daily task. We can monitor whether the person is facing some undue stress, and we can possibly intervene and help that person. So these are few applications which can be done using a state of the off the shelf wearable sensor, wearable device, and the sensors that are there. So yeah, that is it from my side. I'm happy to take questions. I'll stop sharing now.
Thank you, Vic. That was quite enlightening. So that brings us to Al-Musa. Hi, Al-Musa, would you go next?
Thank you so much. And first of all, I just would like to thank the Bengal Chamber of Commerce for the invitation. Very interesting topics and very interesting talks. I'm just going to conclude perhaps the session with maybe some overview. Some of this stuff has already been covered already by my colleagues and the speakers. And it's very exciting to see that there's a great level of commonality when it comes to digital and healthcare. And my topic that I'm going to be covering in this session is slightly delving into kind of some of the AI use cases and automation in general. We've come obviously to learn that automation is highly utilized in different industries, but when it comes to healthcare, somehow it has, in a way, has been kind of lagging behind a little in terms of embracing and adopting these technologies for the better of patients, clinicians, and outcomes in healthcare system in general. So if we look at AI and automation, it has actually become pervasive in lots of areas within healthcare, whether be it staying healthy, as we saw from Klaus and his ability to deal with the various myriads of issues that he's had over his lifetime and dealing with those, but also staying healthy at the same time. In the areas of early detection, and as we heard from some of the speakers, wouldn't it be great if we could use the data and the technology to push the onset of diabetes, cardiovascular diseases by many, many years and actually have them detected early so that the healthcare system can actually deal better with dealing and with those issues up front and avoiding any episodes or complications or ending in hospital, which effectively ends up in costing the healthcare system quite a lot of money. For every hospitalization, the average is around $3,000 to $4,000, whereas for a few dollars, you could actually keep people healthy and avoid having complications. In the area of diagnosis as well, we know that from approved applications, FDA applications, that going through 300 images, a human can take about 30 minutes, whereas a machine can actually take 30 seconds. So again, enabling much more efficiency and much more accuracy, as a matter of fact, with a great level of accuracy to diagnose cases as and when they happen. Supporting in decision-making, of course, there is any human brain is unable to deal with the many data points that are thrown at a clinician from data for the patient, social determinant data, journal data, and so on and so forth. Is inconceivable for a human brain to be able to process all of that efficiently and within a short period of time to be able to help the patients or help the people at large. In treatment, in end of life, supporting with robots, for example, to take some of the mundane issues or activities that a patient has to go through and giving them a level of dignity in terms of being able to look after themselves, but using some other and not being a burden for family or relatives or friends. Although obviously the human touch is very important when it comes to that, but helping with some of those activities in terms of using a robot or so on could help in that aspect. Research, we've seen, as a lot of the speakers have spoken, in this area, the pandemic has accelerated, in fact, the use of AI, automation, data mining, insights to help basically track the disease, the outbreaks, and so on and so forth, but also, expedite the process of finding a quick vaccine, for example. In the area of training, using augmented reality or virtual reality as well, performing operations remotely and in a training kind of environment as well has been possible using automation and AI. So as we see, it is pervasive and it's prevalent in many, many areas. The problem with it all, as some of the speakers have mentioned, is the acceleration in terms of adoption of these technologies and making them more mainstream, as opposed to a pilot or a nice to have, or something that we think about as being on the side and not being utilized in the business as usual of delivering care. Now, that has not been possible, of course, without data. And we've heard from many people today that data is at the essence of digital health in general, and more specifically for AI and automation. So we've seen, obviously, the digitization of our point of care systems throughout the early 2000s. So we've had this tsunami of data being collected. More recently, from 2016 to 2020, we've seen the data fusion, so bringing different aspects of that data, not just from a clinical perspective, but also from social determinants and demographics data and all the various sensors that my colleague has talked about, and fuse that data and actually try to make sense of and correlate some of those aspects in terms of, if I live in a certain area or a postcode, I am more susceptible to having certain illnesses or certain aspects of my healthcare, as opposed to others who live in different areas. So again, fusing that data and understanding really what it, how it could be utilized for the well-being and the better of our patient. And then we're seeing more of the commercializations of those. So, we've collected the data, we fused it, and now we're starting to see commercial models, which is, as they say, money keeps the world turning. How do we actually commercialize those solutions and make them viable for hospitals, clinicians, and technology companies, but as well more affordable for consumers as well? And then moving forward and looking into the future, and this has probably been accelerated even further with the pandemic, is how do we actually make that mainstream and drive the adoption of that across the different segments of the population? And more importantly, as many of you have spoken, bringing the clinicians on board to feel that they're part of this ecosystem and not replaceable by some of these technologies. I think there is a genuine fear that some of these advancements in technologies are going to come and replace the doctor. And I think the view that we have is that these are complementary and supporting the clinicians, but not outright replacement. So we've seen different waves becoming more more mainstream in terms of driving in the last decade the medical products in terms of equipment, consumables, and so on and so forth. Now we're seeing, of course, the surge in terms of big data, wearables, and health analytics, helping us to kind of understand and make sense of all that data, moving into kind of the current and future in terms of focus more on prevention, as we saw from the previous speakers, and having all of that wealth of data and richness of data to help us kind of focus on, what does it take to help certain segments of the population avoid becoming diabetic or obese or suffer from cardiac episodes or complications, and how do we bring all that together to help in the prevention side of things? And of course, looking at beyond that, it's no secret that lots of countries are experimenting with the full kind of connected life, starting from your home into your city, and into which has an impact, of course, on your healthcare, and brings all that together in terms of level of connectedness. And again, we've seen that a lot of these technologies and a lot has been presented in this event in terms of the technology is actually here, but how do we actually bring it together and make it work for the better of the population at large and the patients more specifically? So we've seen obviously the surge in terms of virtual care, using videos and using kind of video consultations and so on and so forth, the wearables and the sensors, as my colleague has mentioned earlier, the diagnosis using the AI agents, obviously the connected homes with all the wealth of data in terms of how how do we track in our own environment, whether be it the home or the city, and so on and so forth. So bringing all of that kind of technology to help us basically move forward with better health outcomes. Now, we've looked actually when it comes to artificial intelligence, we've looked at a number of things in terms of what are the real use cases that we could utilize across the healthcare continuum, starting, as we said, from well-being, prevention, looking more into the patient experience itself, and as Klaus mentioned, actually more self-care, so looking after yourself, being aware of your condition, having the information at your fingertips when you need it and whichever time you need it. We very often refer to the syndrome in healthcare, the white coat syndrome. So, i.e., your healthcare only stops as soon as you leave the hospital or leave the environment where you actually receive the care, more into kind of your surrounding, your own environment, and actually being able to be in control and fully activated and empowered to basically look after yourself and understand exactly what are the implications of some of the decisions that you make in your daily life. Moving into diagnosis, clinical support, as we said, the care delivery itself, and making every aspect of care delivery evidence-based, with targeted plans, with more personalized, as we heard, not one size fits all, but a care plan that actually answers the actual questions and the concerns of the individual, as opposed to a generic kind of way of dealing with things. On the administrative activities side of things, we hear so many doctors and clinicians being fatigued by the level of administration that they have to do. So taking that away and actually automating those mundane activities like revenue cycle management, claims processing, clinical documentation itself, intelligent coding, and so on and so forth. I think all of those aspects will have a much better impact in terms of freeing very valuable resources that have taken time, a very long time, to be certified and become specialists in their own area to do what they do best, which is focus on the patient themselves and take all of that stuff away from them using the automation and the AI. In the public health space, we've heard from many speakers as well, again, in terms of predictive analytics, understanding where is my population or my cohort is actually heading to, what are the interventions and the screening activities that I need to do in order to prevent this, knowing what we know about the population by looking at all the data as well, not just from a clinical perspective, but enriching it from other aspects of our lives. So again, the use case or the case for AI and for automation is definitely here. I think the problem is really making that mainstream and bringing it more into this center and the forefront of how we deliver care. I won't dwell too much on this slide, but again, we've looked at a number of use cases specifically from a clinical perspective, looking at diabetes, maternity, cardiology, urgent care, oncology, mental health, and so on and so forth, and looking at what are the kind of approved solutions or approved methods today that are using some of these digital technologies and AIs that have actually been certified and approved either by FDA or by regulators around the world. And the list is large. And again, the problem here is not the solutions, but actually adopting those and actually making them mainstream in our healthcare system. Looking at the automation itself, as I mentioned, there is a lot of things that have been done in this space, perhaps not as much in the healthcare sector as it is in banking, for example, in transport and other aspects. Looking at kind of perhaps the mundane aspects of the healthcare system, and automating those and taking away the very valuable time of our clinicians and administrators and focusing them on more productive activities and more things that will influence and impact the population at large and the patients specifically. So anything from improving revenue cycle management function, patient scheduling and triaging. We've seen patient flow being directed through the hospital based on the load, based on the availability of clinicians, based on many aspects, and taking kind of that away from just a human person that just sits there and tries to figure out where does the patient move next, how do I move my people from emergency department to different departments within the hospital, and so on and so forth. Claims management in general for those who have insurance-based systems. How do we make those more streamlined and available and more efficient, all the way to managing inventory, digitizing patient files, and so on and so forth. So I think the story is definitely very strong and it's building over time, and there is a lot of usage that we can do from automation and AIs. I think there isn't one talk nowadays that doesn't kind of delve into the impact, of course, of COVID on any industry, and obviously healthcare is at the center of that. And we've seen, as some of the speakers have mentioned, a huge, massive acceleration of using digital technologies because of COVID. Just a very simple example, in one of the countries where I live in the Middle East, they've had a video consultation solution for many years. It only was seeing around 10,000 consultations per year. And within the first month of COVID, that number went to 2 million just in 1 month. So an exponential increase in terms of usage of those sorts of solutions. And that tells us a lot about, when we're forced and we're cornered into and we have our backs to the wall, we think innovatively and we think more about how can we utilize what we have and actually deliver good healthcare to people. So I think I'll just stop here. I know we're slightly over time, but I'll leave you with this particular slide in terms of the overall aspect of how various parts of automation and AI has been able to help at the heart and the forefront of the pandemic, whether be it from a drugs discovery, from a crisis management, from health and risk impact assessments, from speed of prediction and tracking, all the way to actually screening and understanding, the trends within the illness or the pandemic, and where are the kind of next transmissions going to happen. With that, I'd like to thank you and hand back to the chair.
Thank you, Ziad. And that was really informative. And so, do we have time for a few questions? I know that some questions have come in the chat. So I know it's also 6 o'clock, and I don't know whether there are other sessions after this. So do we have time for some questions? We can't hear you, Omar, in case you're speaking.
Speakers of the other sessions have joined. If it is all right, Rupok Boro, you're chairing the next session. Can we take up few questions very quickly?
Yes, you can continue, Sulabna. I mean, this can take, otherwise, or maybe for 10 minutes.
Okay, we'll do that. Thank you, Mr. Bora. So I think I would probably just go ahead with a few questions which we have, sort of come to, which have been posted. One of the questions is, the devices play an increasingly central role in monitoring and supporting, healthy habits and, overall remote monitoring of health, but they also pose significant data privacy risks for users. Any views around this? Yes, Klaus, you can.
Yeah, I would like to. I'm one of the users, and for sure. So I think it's about ethics, and we have very good and very interesting from about the ethics in AI. What I think is we need to learn to respect our privacy. I think one of the bad things of COVID is that all the things we have reached in terms of securing data privacy has technically been set 20 years back, something in regulatory wise. And I think we need to fight back that part. And I think it's important because it's about creating trust. If people lose trust, if you lose trust in a currency and a government, it's bad. If you lose trust in data, it's also bad for AI and healthcare, for everything. So one of the initiatives I'm working with is the Data for Good Foundation. It's only about creating back trust in that we can share data and handle it. The European Commission has played a pivotal role in trying to establish a new way of battling this kind of thinking consumers as a product, and I think it's a bad way. And I think Apple now clearly shows another way of dealing with this. I hope this is a thing that governments will tend to think about, because if we will not share data and people will find other ways, you see how now I'm in Asia, I can see how people in Hong Kong and the Tea Party is moving around with finding other ways of sharing their data. And it couldn't happen in healthcare. So I think it's something we have to really, really take seriously, this concern. And I'm working on a model how to use technology to claim trust using a blockchain. I think that's where we can find some of the answers.
Can I attempt that answer?
Thank you, Klaus. Yeah. Yes, please. Go ahead.
Yeah, the other aspect to this is, of course, with the kind of the data that we have, Klaus, you talked about multi-party computing. There are a couple of terms which are going to be heard more and more often. One is, of course, what we call as the homomorphic encryption, and the second is the differential privacy. It's my intent to introduce both of this term in terms of scalability that we are seeing with lots of people across the different world sharing the data, or even keeping the data within themselves, but sharing the algorithms that they produce to actually go and look into different geographical and ethnic population. And we're seeing more and more of it with the help of homomorphic encryption, where you do not need to actually decode the data or decrypt the data before you actually run the computation on it. And differential privacy is actually doing the computation without using any one of the PHIs, 18 PHIs that we know. So when these becomes relevant, the questions related to devices, data, and how they are handled over a period of time is going to go away.
Thank you, Shuja. Shuja, there was another question that how does penetration testing help? So maybe in the same line, you just...
Yeah, so I already answered that question in the chat bot. So it's a helpful tool. If you're looking at it from the perspective of risk assessment and looking at if you are identifying vulnerabilities in the system, and if you want to look at also what are the strengths of your mitigation strategies. It also gives you a good quantitative and quantitative estimation, helps you to allocate budget and put in right people at the right places to do the work.
Thank you. So I think in the interest of time, I know that we've already, at 6 or 8 and the next group is waiting. So I would probably suggest, Angana, if we can probably publish the email IDs of these speakers after taking their consent, so that, the viewers can probably send in the questions individually. And with that, I would probably just give the control back to you, Angana. Thanks to each of the speakers for such an insightful, discourse. It was quite informative for many of us, and I'm sure the audience would have really benefited out of it. We would try and also check with the speakers if some of the presentations they have shown us, if they want to share that on the Bengal Chamber website after, obviously giving the versions which they're comfortable with. We will try and share that as well. And along with that, we'll try and give their contact email so viewers can probably reach out to them individually if they want to. Thank you once again to all of you. And with that, I'm going to back to you.
Thank you. Thank you, everyone. So we are moving on to the next session, that is users' experience of technology for cloud streaming. The session is continuing. I would request the Facebook audience, we will relive it in a couple of minutes. So we will just take a couple of minutes to relive it. So we have with us Mr. Rupak Borua, Group CEO, MRI Hospitals, who's chairing the session. And in panel, we have Mr. Rajiv Sikka, CIO, Technology Leadership and Program Execution, Medanta, the Medicity Hospital, Dr. Soumitra Varadwaj, President, Medica Super Specialty Hospital, Mr. Partho De, Founder, CEO, U4R-AD Technologies and Director, PAS Digital. We are expecting him? He has joined. Thank you. So Mr. JP Dwivedi, Chief Information Officer, Rajiv Gandhi Cancer Institute and Research Center, and Mr. Suresh Ramu, Co-Founder and Director, Sitespace Research Private Limited. Mr. Borua, I would request you to allow us a couple of minutes. We are just reliving for the Facebook audience, and we'll give you a heads up in maybe 1 or 2 minutes when you can start your panel.
Sure.